Dr. Pallav Mishra. So this is a patient who is a 23-year-old female, and she is having complaints of pain and instability of her right knee. She got a twisting injury while playing, and this injury happened back in January 2025. On examination, she has Latchman positive, anterior draw positive, pivot shift positive, and lateral joint line tenderness positive. The negative findings were there was no posterior draw test, dial test was negative, and medial joint line tenderness was negative. MRI findings that she has is the full thickness tear of ACL ligament, and there is complex tear in the lateral meniscus, and there is partial longitudinal tear in the medial meniscus. So this is the MRI film of the patient. As you see, there is a complete ACL tear and is also having lateral meniscus tear, as you see. So the plan is to go for arthroscopic single bundle ACL reconstruction using hamstrings graft, lateral meniscus balancing plus minus repair. Let's see what SIRS do. So let's start with the live surgery. All prepared. ठीक है, तो मैं यहाँ पे ट्रांसफर कर दिया ट्रांसफर। हाँ डॉक्टर अरविंद का।
पे सेट कर देंगे।
हेलो, तो ऑडियंस So since it may take another 4-5 minutes for the surgeon to start, I would request moderators if they want to discuss the plan of surgery. Meanwhile, they start off with the live surgery.
Good morning.
Good morning, sir.
Yeah, sir.
What are your preferred solutions for doing it? This is probably the leg on the table and then for you the leg go to the left. Who plays the leg and has the leg off. So what you are getting to anybody and faster to starting, which is a better position?
I feel any position is comfortable to start scopy. One thing you need to understand is that you need to maintain sterility. What I started with was leg hanging position after breaking the table. I was comfortable with everything. The only issue was the foot of the patient used to come pretty down at the level of my mid leg at times, and I was pretty uncomfortable with the chances of it getting contaminated by my scrubs. So I shifted to this on the table position. I used to put a bolster on the in the region of the calf, and then I started with this position. And I feel for sterility point of view, sir, this gives a much better comfort level. And secondly, while exposing the lateral meniscus, this position is way more comfortable to give a figure of 4 stress and way more stable. You're not dependent upon somebody holding it in a constant position. The table does the job for you. And I feel, sir, switching to this position some 7-8 years back, it's been way more comfortable journey than the leg hanging positions.
I think that's a valid point. Anybody has different point of view?
Same, I think I also do it with the leg on the table in the TKR position. I have always done it like that. There are other ways of doing it. It's everybody's comfort. You'll have to find your safe zone and comfort zone. But I feel having the leg on the table reduces the need of one assistant who is manipulating the leg when you are going to make your drills. The leg is stable. It doesn't keep wobbling here and there. And as I said, the sterility is slightly better maintained while it's on the table.
Yes.
Hello.
Now the second concept is people are going into would you think the leg shoulder is secure or can you take to the
I don't think it's essential. I have seen them being used during my fellowships. Yeah. But I really don't feel it's too bulky, I feel. And even if you're using that to look into the medial or the lateral compartment, you have to take it out of that leg holder anyways. Yeah, I feel it's more restrictive. And if you have a lateral post and 2 bolsters to keep the knee in 90 degree and 110 degrees, I think that's good enough.
So for the youngsters, I would like to discuss one point. Sir, what do you think is the best surgery when you are starting with your arthroscopy journey? Which ones you should actually start with and which ones you should not touch in your initial years? What's your take on this, sir?
first thing is that the diagnostics, don't start anything else with once you've got it, do your small things. I don't say do body, especially if the good body pulls the back.
Yeah.
Be comfortable with your diagnostics. Be comfortable with your meniscal dissections. Because meniscus repair, especially in the medial compartment, sometimes they are very tight. Then you evolve to the C.
So what's your take on arthroscopic debridement of osteoarthritic knee in the initial phases? In the initial, because almost all my fellows, when they come, they ask me, sir, I don't see you doing much of the debridements. So what if I start with these? I have nothing to lose. So what's your take about just for starting H?
Let me be very honest. From 1994 to 98, we did a lot of it. Then there came this very big treatment from where in the Veterans Hospital, they stopped paying surgeons for arthroscopic debridement for going. Because there was one under not a good scientific study which said that doesn't happen, which I think is wrong. But in the right stage, especially when you have mechanical state, take the water. If it's a seriously, degraded joint, no cartilage, nothing. But if there are mechanical, like locking someone or moving body, debridement, that is one. Second point is you can add to the spread. You can do microscopic. These meniscus are probably never fit for the bed. But they are very, very
नहीं है
fit for debridement. Now there's a downside.
इसमें लटका दो ना कोई बात नहीं
If you have an intact meniscus, it's a buffer between two worn out bones.
ठीक है
If you take it out, there is a more transmission of pressure. There's a downside. But if you go to stages 2 and 3, the benefit is not done. But stage 2 is trying the best with mechanical
ठीक है
not pain alone. But if you study these
ठीक है।
MRIs in detail,
चलो,
you will
super.
find some degree of some further edema in most of them. But
रणधीर
they
नाम है
don't
आपका?
have
हाँ?
inside the
मनीष नाम आपका नहीं लिखा। अच्छा नर्सिंग ठीक है।
do microfracture. And I tell them
8 का
this is
gloves
the
मिलेगा?
first surgery in your journey of your knee.
हाँ?
So they will
8
probably
नहीं है, देखो 8 होगा यार। 8
Exactly,
है
sir. But my take would be when my fellow asks me whether I should start,
वो सब लगा लो।
I tell them it is difficult
Connections लगा लो।
to choose the right patient for arthroscopic debridement of the knee. So if you are not selecting the right patient and having him or her follow up in your OPD and sitting outside every time
7
telling that
and a
his
half
or her pain is not relieved, will be a very big morale, dampener.
Yeah.
So rather than having an unhappy patient and giving you a jitters that whether I have done a right thing or whether I should go ahead or not to attempt these
ठीक है कोई बात
in the
नहीं।
initial
Arthroscopy नहीं है
parts
ना?
of their career, be
हाँ, वो
very
best है।
clear about the indications that you start with, so
वो
that you
best
have
है।
the positive
वो ले
reinforcement and
लो।
not the negative ones. I just remember second year of my scopy, when I started scopy, I had a 44-ish, 43, 44-year female with a debridement for the medial meniscus tear. I had the hell of my time. I had to talk to my mentor repeatedly what to do, and he told me one thing: never operate on a female 45 years of age. Simple. One contraindication: first 3 years of scopy, do not operate. Come what may, just do not operate. Everything that goes wrong in their life is because of your knee. That is when you have operated. So first 3 years, choose wise patients in which you expect results, instant gratifying results, for that positive reinforcement that you are doing it right. Don't take borderline patients initially.
Okay, I think they're starting.
Yeah. So I think Arvind is.
हेलो सिद्धार्थ।
There's no dialogue, right?
हेलो सिद्धार्थ।
As per new NMC guidelines, there should not be any cross conversation.
Would you like to introduce the surgeons?
हेलो सिद्धार्थ।
So I think we have Dr. Arvind there who will be operating and demonstrating
transfer करो ना।
augmented ACL
वहाँ ट्रांसफर
to
करो।
us.
Arvind is an accomplished surgeon from Paras Hamri Hospital in Patna. And we worked together in Delhi some 15, 16 years back. We were both struggling to finding a foot. And that time, it was a different journey. Now he's doing very good work. And
हेलो सिद्धार्थ।
let's see what he does with this work.
हेलो सिद्धार्थ।
They've already informed that they're on
That
screen.
they can start speaking.
I'll just do that.
सिद्धार्थ गुड मॉर्निंग। ट्रांसफर नहीं हुआ है वो बात करो एक बार। टेबल थोड़ा अप कर दो बाबू।
Concept of watching live surgery. I think it's even better if you watch re-live surgery because the
Yes.
discussion can be focused. The
आवाज जा
time
रही
can
है?
be cut short. The
आवाज नहीं
whole
जा रही है?
operation of 1 hour can be shown in 25 minutes.
पंकज,
This is the objection.
प्रेशर
which
सिस्टम भी रेडी कर
internationally, if you
दीजिएगा।
go abroad,
प्रेशर
there's never
सिस्टम
going to
रेडी
be
करवा
live
दीजिएगा।
surgery.
अभी
It's all
यूज नहीं
recorded
करना है।
surgery. But in India, we have this craze. The live देखना है. Let's see how he goes down.
एक सीट चाहिए होगा इसके नीचे रखने के लिए।
That one faces during surgery, sir.
They can still be recorded on the video and discussed. That is what the NMC is now ultimately going to go to. If you record it, record the whole surgery for all you
Height
care,
कितना है मरीज से
and then
पूछो तो?
discuss it. Because the big compliance problem is that if surgeon knows he's live, there could be some error in the surgery because they.
Sound transmission के लिए.
So that's a problem. So are we getting sound from the theater?
थिएटर से आ रही है साउंड? थिएटर से आ रही है आवाज? उधर से बोल रहे होंगे ना?
आवाज नहीं जा रही है।
आवाज आपकी आ रही मेरी, वहाँ की आवाज मेरे पास भी आ रही है। सर की आवाज़ यहाँ से वहाँ नहीं जा रही। माइक में तो प्रॉब्लम नहीं है, आपके पास आ रही है। तो वहाँ एक बार कॉल करके पूछिए ना, सर की आवाज़ आ रही है क्या वहाँ?
ये ऑल से हो जाएगा, परफेक्ट है।
इसीलिए सर मैंने पास तो 45 का है, बट है बहुत फाइन है।
नहीं, इससे हो जाएगा।
आप हिस्ट्री